Good evening, everyone. Welcome to the BioMonde webinar and our guest speaker today. Before we begin, I do want to go through a little bit of housekeeping. So this is one of our expert guest webinars. Very kindly, Carole Young has agreed to present for us today, and she's going to go through a trip through the history of wound care. So I'm very excited to hear about this one. It's going to be roughly a 30-minute webinar, and there will be time at the end for questions and answers. And also, we would love to hear your stories and anecdotes, and please do feel free to share them in the chat box, because this is very much about all sharing our stories around wound care. So if you can't find the chat box, you will see a series of buttons on the top of your screen. You'll see a little speech bubble, and that says chat. So that's where we can talk and share our stories. And next to it, there'll be a Q&A button, and that's where we ask that you put your questions, which I will share with Carole at the end of her presentation. So let me just tell you a little bit about our speaker, Carole, today. She's a tissue viability nurse, consultant and professional nurse advocate. She's has over 25 years of experience in tissue viability and education. She's worked in the NHS acute, academic and independent organisations to support clinical practice and learning for a wide range of clinicians and patients. And as you will gather through this presentation, she is absolutely fascinated by the history of wound care and understanding the journey from traditional remedies through science to modern day therapies. So what we're going to be hearing from her is obviously a history of wound care, and she's going to talk to us a bit about traditional remedies through to scientific discoveries and the development of modern day products. Then on to understanding how our past can help us learn for the future. So without further ado, I'm going to hand over to Carole, and I'm going to stop sharing my screen so she can share hers.
Thank you, Vicky. I'm so excited to be here this evening. I'm just going to share my screen now. And hopefully you can all see my first slide there. As Vicky said, I'm Carole Young. I'm a tissue viability nurse consultant and professional nurse advocate. And I've been in nursing about 30 plus years now, and in tissue viability for 25 years. And along that way, I've heard many a tale about dressings and where they come from, and I've seen lots of developments myself. So I get really fascinated and excited about the history. And hopefully we can bring you a little bit of fun and a bit of a different presentation today before we all get a bit busy with the festive season. And we'll hopefully give some time for reflection on how wound care has changed through the ages and how history has moulded what we do today. So why am I so fascinated about the history of wound care? Well, and that of nursing. Well, it's kind of in my blood. I'm a third generation nurse, and I've got links to nursing and healing and hospital life spanning back at least 4 generations. I grew up with all sorts of great stories of nursing and healing long before wound care as we know it today. My relatives and ancestors were managing wounds with all sorts of things such as poultices, honey, sugar, iodine. They saw the development of hydrogen peroxide and antiseptics. And they were washing and sterilising bandages and equipment that we consider single use today. But my relatives were also witnessing the changes in the innovation and development through 2 world wars and a rapidly evolving healthcare system. So just to share with you some photos, there's me and my mum, who was a nurse and worked within cardiology and paediatrics and all sorts of things. My grandmother was a paediatric nurse who was then seconded into a British Red Cross hospital at the end of World War II to look after military personnel. Can you imagine the change and understanding from children's nursing through to looking after these terribly wounded men coming back from the war? And then my great grandmother was known as a healer. So she was known for using poultices and lotions for solving all sorts of ailments and wounds and sores and things. So I've got a longer history going back, and it's kind of inspired me and pushed me forward in my career. So just imagine some years ago, you find yourself with a festering wound, and the doctor says to you, well, first of all, I'm going to put some maggots in there to clean out the wound. Then I'm going to pack some honey in and wrap it in cling film. Worded like this, you might have wondered about your doctor's credentials. And not so long ago, this would probably have been considered some kind of witchcraft or some crazy medieval folklore. But we now know the science behind larvae therapy, thanks to the research from our lovely friends at BioMonde and elsewhere. We understand the antimicrobial benefits of Manuka honey, thanks to the extensive research at Waikato University in New Zealand. And thanks to George Winter in the 1960s, we know that occluding wounds under film dressings aids the production of epithelial cells and wound healing. So some of our modern wound care products were born out of folklore and stories passed on from generation to generation. We can learn so much from history and science. And it helps us to unravel the folklore and turn it into modern day evidence-based practice. So let me take you on a meander through time, from wound care in ancient Mesopotamia and ancient Egypt, Greece and Rome, through to world wars and modern day. And we're going to look at the evolution of some of the products we use today and where they came from, and how particularly war has been revolutionary in terms of wound care for the developments and innovations that we've seen. So let's get right back to the beginning. Man has been dressing wounds for thousands of years. For as long as man has been on the earth, we've had to survive injuries and attacks from animals and injuries from hunting. So wound care has been the key to survival right from prehistoric times. Our earliest evidence is carvings and ink drawings that suggest early dressings were devised from what was mostly available. It could be anything from mud, moss, leaves, bark, and poultices made from what nature provided. Some of the earliest documented evidence of wound care is found in the Sumerian clay tablet of Mesopotamia, dating back to 2200 BC. Getting my tongue around that already. The tablet describes a process of washing, dressing, and bandaging wounds, using wine, beer, or a sesame infusion to cleanse. Can you imagine how much that would have stung? But that was considered to be safer than water in a lot of areas then. And we've got evidence that wounds were packed with things like pine resin, myrrh and frankincense turned into pastes and applied directly to wounds. There's evidence to suggest that oil was frequently used to prevent dressing sticking and create a barrier. Does that sound quite familiar? You know, we really try and make sure our dressings don't adhere to wounds now. We often use oil-based products as skin barriers. And so these things have been used for thousands of years. But interestingly, more recent studies in 2015, 2018 have demonstrated that the use of myrrh accelerated wound healing in animal studies compared to a control. And frankincense has been shown to increase collagen synthesis and angiogenesis in diabetic foot ulcers. So these things that we think that, you know, we've heard these things from Bible stories and ancient text, they're actually could potentially become our next big thing in wound care. So look out for your myrrh and frankincense dressings or pastes heading our way anytime soon. I think the ancient Egyptians made the most fundamental steps forward in wound management. They may not have known completely why certain things worked, but they recognized that some things worked, some things didn't, and they documented. And they're one of the earliest documenters of wound care and medicine. And they observed the benefits of what they were using and what they did. So papyrus from ancient Egypt, dating right back to 1700 BC, documents the use of bandages being soaked in cream and bean flour, which then hardened as they dried, creating a stiff cast, long before plaster of Paris was invented. But could this have also been a early form of paste bandage like we use on leg ulcers today? or even compression. If as bandage hardens, it shrinks and tightens. So we're actually creating a compression bandage back in ancient Egyptian times, and probably not recognizing the anatomy of the veins and arteries and how that was benefiting the people they were bandaging. The ancient Egyptians were also the earliest recorders of wound healing using honey and silver powders, saline solutions, and padded linen dressings and bandages. It's documented that they used lint coated in an animal grease to stop dressings from sticking. So they actually created an early form of a non-adherent dressing. And this has continued right through history, right through to quite recent history. We've seen dressings coated with a grease to stop them from sticking. CT scans of Tutankhamun showed that he was suffering from an open fracture and an infected wound to his leg when he died. He also had avascular necrosis at the site of a clubbed foot at the time of his death. So he was probably suffering and probably in quite a lot of pain, I should imagine. But interesting that those scans also identified a dressing to that open wound made of resin, which was secured by tight bandaging. So it almost sounds like modern day wound care products sometimes. Cleansing solutions being used, salt water saline. What we understand from those scans that Tutankhamun had recently was that his wound was dressed with a resin, and that was probably a sap from local trees. And the Egyptians would have seen how the trees excrete sap from the cuts in their trunks, and then it solidifies and seals the damaged area. And from this, they would conclude that this could help with wound healing as well. And Egypt was much greener land then than it is now. And the variety of trees, things like pines. And we know from very recent science that the resin from pine trees is now found in a modern day dressing product, and it's got really good anti-inflammatory and antimicrobial products within it. And we also know that extensive research into honey and silver has identified the wide range of antimicrobial, antifungal and antiviral effects, as well as its anti-inflammatory actions through osmosis in honey. So it really does appear that the Egyptians were the forerunners of modern science, and a lot of our modern dressings we can thank the ancient Egyptians for. But they weren't the only ones using tree sap in wound care. There's a long history of making ointments from pine resin. And I can remember an incident many years ago when I was asked to review a Russian gentleman admitted to my trust with recurring leg ulcers. His daughter had proudly presented us with a jar, unlabelled, of an ointment that appeared to be quite greasy in nature, and she'd been using it on her dad's legs and describing it as the very best thing in Russia for healing ulcers. And it was made from pine resin. Now, at the time, I'd never heard of anything like this. I'd never come across a product made from pine. As we know, as a healthcare professional, not a good idea to be using an unlabelled, unlicensed product that our patients' relatives bring in. But as a good TBN, I went off and I did my research, did a literature search, and was really intrigued to find this ancient remedy was indeed being researched, and the elements were being extracted from the resin went on to develop the key ingredient in a very recent commercial available product. So I guess the moral of this tale is never dismiss those stories about ancient remedies and those stories that we get coming down in history. There's a lab somewhere gathering all the evidence, and someday you'll see it in a commercial version. In more recent times, we've seen acetic acid and vinegar being shown to be effective against resistant pseudomonas in wounds, but it does make for a really painful experience for our patients. And this comes from the Greeks and Romans using wine and vinegar as an antimicrobial. And they were the first to sterilize dressings by boiling and introducing hand washing. But we know that these things sting, and we know we would only use them as a last resort now. The ancient Greeks were the first to recognise the difference between acute and chronic wounds, calling them fresh and non-healing, which is really interesting to recognise the difference and maybe treating them differently. We've seen documentation by Homer in 800 BC describing the use of bitter herbs being applied to battle wounds in the Iliad. And I wonder if that was similar to the myrrh and frankincense that we saw being used in even earlier times. And the use of silver and copper has been documented in Roman and Greek history as well, mixed with vinegar to make a copper sulfate. Now, those of you who know about some of the very recent dressings that have come on the market will know that there's a copper sulfate dressing called MedCU out now, which is being shown to be a really good antimicrobial. So there's a lot, again, in history coming forward to our very recent developments of dressings. The Romans also used sea sponges to absorb exudate. And these, we can see these as the predecessors of modern day foam and of superabsorbent dressings. Evidence shows us that the removal of excess exudate maintains the correct level of moisture for epithelial growth and healing. So whilst natural sponges would only have been useful until they were fully absorbed, modern foams have a lock-away core to keep the excess fluid away from the wound bed and trap the bacteria within them. But it's really interesting that these Romans and the Greeks, the ancient Egyptians, were doing all this stuff, but not really understanding why they were doing it or what effect it was having. But it was definitely having an effect. In the early years AD, we have a Roman physician called Celsus who identified inflammation and also started to use some form of antiseptic solution. He was also advocating for early suturing of fresh wounds, so acute wounds, and debridement of chronic wounds, which we use these theories today to promote wound healing by getting debridement going. And Claudius Galen, a Greek physician who moved across to Rome to treat gladiators, he had such success in his wound healing that he was considered the father of surgery. He introduced moist wound healing and the removal of pus, recognizing this was not a good thing to stain wounds. And he introduced the control of bleeding with compression when he was treating these gladiators with their quite horrific wounds. But it's a little bit sad to know that the work that Galen did way back in 200 AD wasn't actually really picked up by modern wound care until the 1960s, when George Winter did his research in moist wound healing, and it was really more understood. Up until the 16th century, the surgeons believed pus was essential and actively encouraged its production by putting things into wounds like sticks and pokers to produce pus, because they thought this was part of the wound healing to get all this muck coming out of a wound. It was only in the 1500s that the French military surgeon Paré realised that cleansing and good nutrition were actually the key to wound healing, and producing all this pus was not actually a good thing. It took until the 1800s, though, before antiseptics really started to be used more in wound healing. And silver nitrate was quite popular. Remember those silver powders the ancient Egyptians were using? Well, silver nitrate was the next step up and was really popular in the 1800s. But also things like chlorine and carbolic acid. These are the things that people have scrubbed doorsteps with and cleaned swimming pools in modern day with. But these were being used on open wounds. Can you imagine how much that stung? Florence Nightingale, big hero of mine, she recognised the risks of infection in bed sores if bedding wasn't frequently changed. She recognised that saturated bedding led to moisture-related skin damage, and she was an advocate of thorough hand washing, and she advocated the changing of bedding frequently. In fact, she recommended in the home that somebody who was bedbound should actually have two beds, and they should be moved to a second bed so the first bed could be cleaned and dried out before returning. When we get to World War I, and as I said, wars were a real time of innovation and things being developed. And the trench warfare in World War I saw so many awful infected wounds. The introduction of antiseptics really grew. And we saw the introduction of things like iodine. And for those of you who've been nursing for a very long time, you might remember Usol. Usol was an antiseptic solution made from chlorinated lime and boric acid. And it was developed by a military surgeon called Alexander Murray Drenning to treat increasing numbers of soldiers that were arriving at field hospitals from those very muddy trenches, and they were infected with gas gangrene, leading to death and amputations. And he successfully showed that this solution could reduce the number and the severity of amputations by cleansing open wounds as soon as possible. And he went on to try and develop it into a portable product in a small bottle so that it could actually be used in the trenches as soon as possible. Iodine remains the most widely used and evidence-based antiseptic in surgery and wound care still around the world, and very little evidence for it not being any good. It's a fantastic antiseptic. We saw the use of some silver dressings in suture material and eye drops, but it wasn't really that popular once antibiotics came into play. We saw silver drop off for quite some time. But as you know, silver has re-emerged more recently. During World War I as well, we saw the emergence of tulle dressings, so things like Bactigras, Gelinet, sheets of gauze, that unwoven material that were coated in a grease or oil-based ointment to produce a low adherent dressing, very much like those lint dressings that were used in ancient Egypt. So they were still there, they just re-emerged when the need arose during World War. Then prior to the 1960s, we had very little use of moist wound healing. It was very dry. Film dressings were developed in the 1940s. We had cling film and adhesive film dressings, but they weren't really being used very effectively until after the 1960s. The general view before 1960s was that a dry environment was still recommended, that dressing materials like cotton wool, lint, gauze were placed into wounds and allowed to dry out and almost form a scab or encourage a scab. It was seen as a debridement process by removing the non-viable tissue that adhered to materials once they've dried. It was known as the wet to dry technique. Very sadly, it's actually still used in certain parts of the world. This involved putting wet gauze into a wound, letting it dry out completely, and then ripping it off and taking the dead tissue with it. I can't imagine how painful that could be for somebody to go through. And imagine also it peeling off a good healthy tissue as well, those granulation cells getting stuck to those dressings, almost making that wound go backwards rather than forwards. And really interestingly, there's a great book showing the history of the Royal London Hospital, and a nurse there is quoted as describing the feeling of shock as tumour tissue came away with the dressing in the 1950s. And even by the 1960s, nurses at the Royal London were still reporting the continued use of dry healing by nursing burns patients with open wounds on bed sheets and pillowcases, and having to change them many times a day as they soaked through and adhered. Now, as a nurse, I think I would have been distressed seeing that, and goodness knows what the patients went through as well. And the amount of laundry as well that was gone through without any dressings being used. They were often quoted as saying wound assessment and dressing choice was described as just look at what came off and put the same thing back on. It's not really the way we look at wound assessment today and how we change our wound management depending on the condition of the wound. So it's good to see that we have moved forward. In the 1960s brought about George Winter's work, where he compared dry wound healing versus moist wound healing. And the way he did this was he set out to question the practice by doing an experiment. He trialled a film dressing on acute wounds on 2 pigs. Each pig became their own control because each pig had 2 wounds, one of which was left open to the air, so dry healing, and the other wound was covered with a cling film or film dressing and occluded, thus keeping it moist and warm. And what he found was the rate of epithelialization was much faster in those wounds that were kept occluded under the dressing, and in fact the increase in healing was by 24 hours faster in moist than compared to dry dressings. And these results were really highly significant, even though it was a very small study. It led to a lot of future studies in moist wound healing, plus the production of most of our modern dressings. Things like our hydrogels, our gels, our film dressings were all produced because of George Winter's work and the evidence that moist wound healing improves epithelialization much quicker. But despite all that evidence, we had a bit of a blip in the 1970s. I think that's the best way to describe it. And we had some very interesting things being used in wound care. Egg white and oxygen, and I still hear people asking about this today. And nobody really knows how it came about. How did we end up putting egg whites on our pressure ulcers and then wafting an oxygen mask at it? What were we trying to achieve? It is recognised that eggs contain protein and that oxygen is good for cell regeneration. But actually, there was also quite a lot of concerns in the 1970s with salmonella in eggs. And all the oxygen really did was dry out the egg and form an occlusive barrier on the skin. So actually, what were we creating? Were we creating that early moisture barrier rather than treating our pressure ulcers? There are a few varieties to this dressing plan as well in the 1970s, with egg and sugar being used. Sugar has been used for a long time in wound healing, much like honey thousands of years ago with the ancient Egyptians. We know that sugar's got a really good osmotic effect and draws out exudate, draws out infection, and deprives bacteria of the nutrients that they need to survive. So there's kind of something in the egg and sugar, I guess. But imagine the nursing time of standing in the sluice or the treatment room, mixing these products up, not exactly sterile dressings are there. Then we had a really odd moment of trying insulin mixed with egg. Now, unfortunately, this had a rather catastrophic result in causing hypoglycemia, as of course the insulin was absorbed through the open wounds. So fortunately, that one didn't last very long and disappeared rather quickly. We've also seen things like soap and methylated spirits being rubbed into the skin, and talcum powder, zinc ointment. Now, the thing with methylated spirits and talcum powder is that they're actually going to dry the skin out. They're going to remove any moisture from the skin. So the skin has become dry, less elastic. And the practice of rubbing it in is going to create friction and shear that only exacerbated any pressure ulcer that might have been developing. Thankfully, we've moved on. So let's have a look at a few of our modern day products today that we haven't spotted so far in our amble through history. So first of all, hydrocolloids. Hydrocolloids have been around for quite a long time. The first evidence of hydrocolloid technology was found in 1937 in dental care. And it was a sticky substance used as a fixative for dentures and bridges and inlays. But what they also found in dentistry was that it was quite good at covering ulcers in the mouth and on the mucous membranes and protecting them and allowing them to heal. In the 1960s, the hydrocolloid technology was developed into a stoma paste and was used to secure stoma bags. But what was noticed in that process was how well it helped the surrounding skin as well and protected surrounding skin from what was coming through the stoma. And its first use in wound healing was following that George Winter work in moist wound healing, and it started to be used as a dressing. Further research has established that a moist, humid atmosphere provided by hydrocolloids also reduces pain, and particularly if the nerve endings are exposed in a deeper wound, that moist environment created by hydrocolloids protects the nerve endings and helps to reduce those pain triggers. And it also produces better quality tissue in healing, so better quality granulation tissue by keeping that warm, moist environment. Hydrocolloids are a really good protective barrier when we're using larvae therapy. They're really good things to put around the surrounding skin. We don't want our larvae to be in contact with them though, because unfortunately larvae don't really like hydrocolloids. So we would just want to keep that on the skin to protect the good, healthy skin, not into the wound. And more recently, you might have seen hydrocolloids even moving into the beauty market. I've seen them being used as a treatment for acne, cold sores, and even wrinkle reduction. Now, I'm not sure quite how they work. I suspect it's just by the delivering of moisture to the skin to reduce the wrinkles, but just improving the skin condition. But probably for acne and cold sores, it's about the occluding those areas so the bacteria can't survive, the virus can't survive, and then the skin can heal. Our next group of dressings that we've seen develop over the years are the alganates and hydrofibers. The first use of alganates was in food production as a stabilization product. And a really fun fact is it's alganate that holds your bubbles in champagne and keeps them floating. It's also been used in toothpaste and other products like that. Alganate is an extract from seaweed, and it was first used in wound care in the 1940s when it was found that the calcium ions within the product aided hemostasis in bleeding wounds. So if we think about World War II again, thinking about bleeding wounds, traumatic wounds, anything that can help stop bleeding would be incredibly useful in a war situation. And then we saw a really big upsurge in commercial production of alganate dressings in the 1980s, again, being used as a hemostasis and exudate management. And we saw them being produced as that fibrous dressing that we probably recognise today in terms of things like Calcistat, Sorbsan, those kinds of products. And then more recently, we've seen a synthetic version of alganates being produced, known as a hydrofiber. And in their dry form, they look very much like the alganates in that they're a fibrous product, but they're known for their ability to absorb huge quantities of fluid. They've got some of the same ingredients as hydrocolloid within them. So once they're absorbed, they become a gel, which produces a moist, warm atmosphere, much like hydrocolloids, much like George Winter's work proved helps with healing. And they bathe new granulation cells really well. And they're atraumatic to remove because they've turned into a gel. They don't stick to the wound, so they're removed really easily. And then silver. Well, I mentioned silver earlier. It was used in ancient Egypt and Greece as a silver powder. But it hasn't been really that well used until the 1960s. 1968 saw the invention of sulfasalazine cream for burns. And otherwise, you probably know this as flamazine. And this really revolutionized the management of traumatic wounds and ended the stripping of tissue from these adhering sheets. Remember what I said about the royal nurses in the Royal Hospital having sheets and pillowcases stuck to open wounds. This cream was revolutionary. So applying this in good thick layers coated these burns, protected them, allowed them to have padding and dressings to be applied, and prevented things from sticking and allowed epithelialization to take place. We've had extensive research over the years in the benefits of silver, and that's led to the development of many products on the current market. I think we were drowning in silver dressings a few years ago. It was like the big thing. Everybody was producing a silver dressing. But there have been some concerns. Cost is one of the concerns. Silver can be a little bit expensive as a dressing. And there has been some evidence of silver resistance, and particularly in the flamazine and the sulfasalazine, there's been some resistance to the antibiotic that's used in that. So this has resulted in some places that silver dressings are quite often restricted, and you might find that in the areas that you work, that you're only allowed to use it for a couple of weeks and then you have to change. And this comes out of those concerns. And sometimes we find that they're restricted on wound care formularies as well. And of course, it wouldn't be a BioMonde presentation if we didn't talk about our lovely friend, the maggot, larvae. Another ancient remedy that's evolutionized to modern wound care, a product that's got roots in many civilizations, ancient and new, throughout our timeline of history. We've got historical references to larvae in wound care dating back to 2,000 years before Christ, from all over the world, from Maya civilizations, Aboriginal tribes in Australia, and the hill tribes of Burma. There's biblical reference to maggots as well. Job was said to be clothed in worms due to his loathsome and painful sores. We can only assume that worms were meant maggots because we haven't found any good use for worms in wounds. Paré was credited with documenting the impact of larvae in cleansing wounds way back in 1557. He noted that the patient recovered beyond all men's expectation. Though Parr did not understand quite how maggots came to be in the wounds, he thought they were being generated within the rotting flesh themselves. So still a lot to learn in 1557 about anatomy and about where maggots come from. During the Napoleonic Wars in the 18th century, the military surgeon Baron Larry found them were using them for wound inflammation, gangrene and tetanus. He had a really hard time, though, convincing his patients that larvae were promoting health by eating the dead flesh. I suspect there still is a bit of a misconception sometimes that larvae mean something's dirty and that it's infected. And actually, it's almost the opposite. If you've got larvae in a wound, it's going to be clean and free of bacteria because the larvae will destroy the dead tissue that contains those things. Zacharias in 1904, who was a military orthopedic surgeon in the American Civil War, he stated that maggots clean a wound in a single day much better than any agent we had at our command. And he was the first to document applying larvae deliberately to remove gangrenous tissue. So not just finding it by accident like Paré, but actually deliberately putting the larvae into a wound to clean it up. And on this side of the ocean as well, we were seeing the use of larvae during World War I. There was a really high mortality from war wounds, up to 75% of soldiers were dying because of the wounds they had. And those who had delayed transfer to medical facilities were found to have larvae infestations and quite clean wounds. So one surgeon, W. Beer, noted 2 surgeons presented 7 days after wounding, and they were riddled with maggots, but with the most beautiful pink granulation tissue that you can imagine. And so he was so taken by the effect of these maggots in these wounds that he actually introduced larvae therapy into his clinical practice. And he probably carried out the first clinical trial by treating a group of children, 21 patients who had chronic infection and recurrent osteomyelitis because of non-healing wounds. And he found all 21 patients healed without any complications after the use of larvae in their wounds. Now, for some reason, larvae dropped out of favour a little bit after this, probably with the mass production of antibiotics and penicillin. But then we've seen maggots and larvae becoming a bit more popular again since antibiotic resistance came about, and this has led to the publication of many clinical studies, and I think you can find quite a lot of those on the BioMonde website. There's a lot of evidence now demonstrating the positive effects of healing, but also that the enzymes that larvae produce and how they break down dead tissue, they neutralize bacteria and can really help to heal wounds. And larvae are now widely used right across the world as an effective debrider and manager of wound infection. So just to finish off then, what has history taught us? What has research and innovation found through looking at all these dressings through the years? Let's finish with just a little summary of what we know makes for the optimum wound management product. We remember George Winter's work with pigs. This forms the basis for all of our modern moist wound healing dressings. When he found this improved granulation and epithelialization with a warm, moist, humid atmosphere. We also now know that cells slow in reproduction if they're left to be cool. So we want our dressings to maintain a high humidity between the wound and the dressing. We want it to have a gaseous exchange, which allows for the phagocytosis and epithelialization to occur. But we want the wounds to stay warm because we know that that's going to prevent a fall in cell reproduction. If wounds are cold, cells stop reproducing. So they just become static and wounds don't heal. We want our dressings to be impermeable to bacteria, because we know that if we can prevent bacteria, that's going to help with healing. And we want to be able to remove excess exudate and toxic compounds. Remember those ancient Egyptians and their absorbent lint coated in grease to prevent adherence and create a barrier, and the Romans with their sea sponges for absorbance of exudate, and Paré in the 18th century advocating that wound cleansing and the antiseptics and the development of iodine dressings in World War II. These things have all helped us to come to the conclusion of what our optimum dressings are. We want our dressings to be free from particles. We don't want bits left behind in our dressings. And our modern day low adherent dressings, our absorbent foams that have got lock away cores, they all help to keep our dressings free from particles. And we want our dressings to be able to be removed without causing any trauma. We know right from the ancient Egyptians that we need to coat our dressings with something to stop them from sticking and adhering to our wounds. And you'll be surprised to see this list was actually written in 1979, but it hasn't changed very much at all since then. We would still use these criteria to find our perfect dressing, but there is no one particular product that does it all. And that's why we have a range of products. But with all this talk of dressings, let me leave you with one last thought. Florence Nightingale was quoted as saying, "Surgery removes the bullet out of the limb, which is an obstruction to cure, but nature heals the wound. And what nursing has to do is put the patient in the best condition for nature to act upon him." So in other words, nature will heal the wounds so long as we give it the best conditions and care. And we do that through our holistic assessment and holistic management, as well as our dressing products. Thank you very much for listening to my whistle-stop tour through history. If you're as fascinated as me, then there's some excellent reading materials that delve deeper into the origins of modern wound care, and that reference slide will, I think, be available to you afterwards. And I'm going to stop sharing my screen and let Vicky come back on.
Thank you very much, Carole. That was brilliant. And I certainly really enjoyed listening to our whistle-stop tour of the history of wound care. And I find it quite interesting that it seems to kind of go round in circles a little bit. So what we were doing in the ancient times is we're suddenly realising actually that they had a bit of a point there, and we're going back to some of that stuff.
Absolutely. We look at those ancient Egyptians, so they've pretty much written our wound care formulary for today, haven't they? Yeah, we've got wound cleansing, we've got antimicrobials, we've got our absorbent dressings, our low adherence. They're all there way back in history. But what's really fabulous now is that we're using science to give us the evidence behind them and understanding much more why they work, which is probably what was missing in ancient times, was the science.
Absolutely. It's absolutely fascinating. So for everyone joining us, if you would like to share a story, or if you've got a question you'd like to put to Carole or myself, or maybe your predictions of where wound care is going in the future, then now is your time to do that. Whilst you're doing that, though, whilst you're typing, I'm going to ask Carole, where do you think wound care is going in the future?
Oh, fascinating. Well, I was really fascinated to find, doing a literature search, finding that there's actually modern research going on right now into myrrh and frankincense. And it seems very appropriate for this time of the year, doesn't it? You know, we think about those wise men bringing, you know, frankincense, myrrh and gold. Well, maybe they should have brought silver, and then it would have been, you know, we would have had the 3 wound care products right there at the beginning of time. So yeah, I absolutely find that absolutely fascinating, that these things that were used so far back in time, that researchers are going, there might be something in that. We'll just have a little look at that in the lab. And we've seen that with, you know, the emergence of copper, the emergence of the pine resin dressings as well. just seeing how science is picking those things up. I've got a fabulous book which is called Honey, Mud and Maggots, which which is actually out of print. You have to hunt it down. But one of the things that they talk about, lots of things in medieval times that we used, and one of the things was spiders' webs. Now, I would love to see some science into those enzymes. I'm terrified of spiders. I hate them. But spiders' webs, you can look at them and you can see how that could become a covering. But is there something in that sticky? It's got a slightly sticky feeling. If ever you've walked into a spider's web, you get a bit sticky. So I'd love to know, what is it in a web that maybe has a product that can help with wound healing? Because that would be quite interesting.
So maybe that's the future, isn't it? Spiders' webs dressings.
Yeah, you heard it here first. I'm looking forward to BioMonde taking on more creatures. That's what I'm looking forward to.
That maybe you never know. Well, it doesn't look like anyone's got any questions, so clearly you have given
stunned everyone into silence.
A good presentation. So what I'm going to do is a little bit of final slides housekeeping, and then everyone can go off and enjoy the rest of their evening. And this is where I have to try and get my slides back up again. So I do hope everyone has enjoyed the presentation. Am I on to the right slide? Yes, so we've done that one. Okay. If you have enjoyed this presentation, there are other ways that you can get more information. You can watch this back. This presentation will be online on our website, but we will be having more webinars in the future. So please do check out our website for those, and you can register through the website for those. If you would like to learn more about larval therapy, including a little bit more about the history of it, there's many ways you can do it. You can watch all of our videos in the BioMonde Now section. We have our module-based training, which is called BioMonde Academy, and you can book an online session with myself through the BioMonde Direct section. So please do. Oh, we have a question come through, so I'll answer that in a minute. If you want to ask me any questions after today, you are welcome to. You can telephone or you can email, or there is a lot of answers to questions on our website. And of course, please do share that you've been on this webinar today on our socials. I strongly recommend going onto LinkedIn, and particularly following our friend Marvin the Maggot. If you haven't found him on LinkedIn, he is certainly entertaining, I think it's fair to say. But before I leave you, I will just answer, we've had one question which I believe is aimed at me, asking if we can use larvae on a devitalised tendon, which is very interesting. Now, Carole, I don't know if you've ever used on these sorts of wounds, but certainly the advice I would give is, if you want to use larvae somewhere where you have a devitalised tendon, it's important to be aware that our larvae will debride any devitalised tissue, including tendons. Obviously, it depends on the ongoing plan for that individual patient as to whether you are happy for that to happen or not. So arguably for some patients, if the tendon is necrotic, then it's probably not going to be doing much anyway. But like I say, it depends on that individual and whether that is appropriate or not. I don't know, Carole, if you've got anything you'd like to add to answer that question.
Yeah, I from my experience, I would just be a little bit cautious. I would want to know, I would want to be knowing, is it definitely completely devitalized and dead tendon, or is it just dried out because it's been exposed? Because a tendon that's been exposed for a little while can look devitalized, but if we rehydrate it, and I would usually recommend some kind of hydrogel dressing is probably the most likely dressing to use on a tendon, and you rehydrate it, you might see the color return, and you might see the elasticity return, and it may still have function. So that would be my cautionary note. Is just make sure it is devitalized and it's not just dehydrated.
Yes, and I guess in a way, if it is just dehydrated, then the larval enzymes will help to rehydrate it because they're introducing moisture. But yeah, you're right, Carol. Making sure we know exactly what's going on in that wound before we're putting larvae on is very important. So thank you for that question.
And I think somebody's just mentioned about arteries as well.
Oh, yes, we have. Yes, so when it comes to blood vessels of any kind, especially large ones, as with we were talking about tendons, larvae will break down anything that is devitalized, and that does include blood vessels. So you do have to be very confident if there are big blood vessels involved in that wound bed that they are not necrotic before you put the larvae on. Otherwise, you're going to be in a bit of a pickle, let's say. So any doubt, we would generally advise using something a little bit more gentler, because you certainly don't want that risk of heavy bleeding. Hopefully that's answered your questions. If you've got a particular patient you want to talk about in mind, then please do feel free to get in contact and we can have an anonymised conversation about that patient. But yes, unless there are any other questions, I can't see anyone typing or anything, then we will leave you in peace. One last thing I will say, actually, before we leave, is we are always looking for larval therapy advocates. So if you are particularly enthusiastic about talking about larvae as much as we are, and you want to spread the word, then please do get in touch, because we are looking for friends and colleagues to share the love, and we will make you an exclusive member of our club. You'll get a badge, and you'll get to become best friends with me. Oh, Carol, we can definitely get you a badge, absolutely. And we will be holding special events for our advocates as well, so please do get in touch and let us know if that's something you'd be interested in. But otherwise, thank you so much for joining us today, and thank you so much, Carol, for your wonderful presentation. It really was very interesting. I'm really looking forward to watching it back several times after today. And I hope everyone has a wonderful Christmas, and we'll see you again for another webinar in the new year. So thank you very much, guys. Have a good evening.
Thank you.